Welcome to Dementia-Friendly Prince George's County, Maryland Northern Sector webinar series for caregivers. Today's topic is Living with Serious Illness, Myths and Misunderstandings, presented by Miriam Ponce and Kady Adeleke, sponsored by Prince George's County Government and the Department of Family Services.
Hello, everyone. Thank you for giving us the opportunity to be a part of this program. Again, I'm Kady Adeleke, and I am the Director of Nursing at Interim Healthcare of Prince George's County. Today, I will be talking about transitional care and how we can better support our clients and our seniors in the community. We can go to the next slide. Okay, the transitional program. Basically, the transitional program is a comprehensive program that is focused on patient-centered support, and meanwhile is also preventing gaps in care. We are able to do this through our home life enrichment program, which I'll talk a little bit more about. Our home care service line, personal care supports, the palliative care and hospice care, services, which is partnered and provided by Hospice of Chesapeake. We can collaborate with each patient to improve the quality of care and to increase patient satisfaction. The transitional program really is created to help reduce the number of returns to medical office visits and also to reduce unwanted readmission due to unmanaged symptoms. Again, at Interim Healthcare, we are committed to providing quality of life for each patient under our care and helping families and caregivers. So what does a typical patient or a client would look like for us? It would be someone who has functional changes or decline, maybe in the past 6 months, someone who is requiring more assistance, maybe doing their errands, someone who requires assistance with meal prep, requiring assistance with maybe their housekeeping, someone who is unable to drive, or someone who was more functional in the past, but just due to health reasons, they are unable to perform this task. Also, maybe someone who has changes in their energy, or perhaps maybe they're not able to ambulate due to their health. Maybe also someone who has my health special needs for bowel and bladder control. A person who requires assistance with repairs or maintenance of their home. And lastly, maybe someone who needs assistance in paying bills and writing checks. Basically, someone will be an elderly or someone who has a medical condition that has prevented them to to do certain tasks that they used to do before this medical condition. So our job is to help to support both the patient and the caregivers. How can PCSS help? So PCSS is our personal care supports service line. And through this, we're able to provide companionship for clients, perhaps who lives alone, who is active, but maybe they just live alone and maybe their children are not able to maybe visit as often. They just need someone to maybe come to the home, help them, be there with them, make sure that they're taking their medication. If they need assistance with bathing, grooming, we can provide light housekeeping. We're able to provide to accompany them to doctors' offices. We can run errands, transportation, either to their doctor's appointments, or even if they just want to go to the mall or do something that they usually do, maybe go to a senior center, but they're not able to drive. We're able to provide the transportation through our PCSS line. Also, we're able to do meal prep and also meal planning. Transitioning between service lines. So when PCSS can help, so clients, like we mentioned, there are needs additional assistance with your activities of daily living. They need assistance with personal care and errands, transportation. someone who has isolation, needs companionship, basically all the things that I mentioned in the past. But we are able to, this can be reimbursed under Medicaid waiver, commercial insurance, long-term care insurance, and if the client or the patient is a veteran, we do also accept aid and attendance long-term benefits for veterans. Um, with the personal care supports, because this is not a skilled care, is more of it doesn't really, not all the time requires licensure, but we mostly will provide you with certified nursing assistants. Um, and this is tax limited to non-clinical that we'll be providing. Again, just like personal care support, grooming, transportation, companionship. Again, it says PCSS is compatible with existing home health or hospice services. Okay, and then our home health line, we're able to provide skilled observation and assessment in the home, new diagnosis, teaching, and training. So a nurse will be able to come out and do teaching for new diagnosis, especially with our chronic conditions, especially like with diabetes, coronary artery disease, heart failure, and COPD. We have a very strong home life enrichment program, and our caregivers will be able to, not just teach the clients on managing their diseases, but also the family members as well. The nurse will be able to manage and evaluate the patient care. We're able to provide IV and medication management and teaching. As I mentioned, we can do diabetic education and use of glucometer and insulin. Being able to report on favorable responses and reactions. Individual and family counseling related to diagnosis can also be provided. Home safety and emergency education can also be provided. So basically, this is just our home health care line. We're able to provide a nurse that will be able to help and do more of skilled nursing care at home. We can move to the next slide. So a client or a patient that is in hospice, how would this person present? And I know Miriam had a great presentation. She'll be able to talk to you more about this, but I'll just briefly talk a little bit about it. So someone receiving hospice care, how did the person present? There will be someone who has poor response to treatments. They might desire to stay out of the hospital and focus on comfort versus cure. And someone with weight loss in the last 3 months of at least more than 10% body weight, decline in ability of care for self, walking, moving, or transferring, a person with recent complications such as pneumonia, infections, and decubitus ulcers. At Interim Healthcare, we're able to provide services that would support both patients and the family, which includes medication management for this client, nursing care, social services care. Again, this would be in partnership with the Hospice of Chesapeake. We're able to provide spiritual care and personal care as well. Care will be focused on quality of life when the quality is short, and also addressing what is important to the patient and the family for comfort. We're able to provide supporting wishes and decisions at the end of life. Payment for related medications, medical equipment, and supplies, again, with partnership with Hospice of Chesapeake. And also, we're able to provide 24 hours and day call services. Thank you so much. That is my part of the presentation, and now I will forward it to Miriam.
Thank you so much, Kady. I appreciate it. And thank you so much, everyone, for joining us this evening. I am so grateful to be here and excited to talk about living with serious illnesses, myths, and misunderstandings. And I'm also very just happy to be here and just talk about, hospice and palliative care and see how we can help. So I want to start with a quote that says, like education, healthcare also needs to be given importance because it's very important to talk about healthcare, not just decisions, but also like what does it mean to have diabetes. Just get very educated about all these chronic diseases that are out there, especially in our communities. A lot of the times we go to different specialists. The doctors don't talk to each other. We go home with a new diagnosis and we have kind of an idea what's going on, but we don't know the exact ins and outs of the disease and how it's going to affect our quality of life. Understanding supportive palliative care in hospice. So with hospice, the disease follows the expected course and a prognosis of 6 months or less. Patients often refer late. Sometimes the patient can last longer on hospice, or sometimes if they're referred late, they may pass right away. Depends on when the referral is made. Supportive care, palliative care, this is focused on symptoms, anywhere throughout the disease spectrum. So someone that is newly diagnosed with cancer, someone that is newly diagnosed with a chronic kidney disease can benefit from supportive care. Once treatment is no longer an option, then we can go ahead and refer them over to the hospice. So there is always a continuum of care. Myth number 1, palliative care, supportive care, and hospice care are the same thing. Not the same thing. While supportive care and hospice care have similarities, they are not the same. Supportive care, palliative care is available for anyone facing a chronic or terminal illness that is diagnosed earlier, in which the practitioner meets the special needs of a person. With supportive care, symptoms can be relieved and an individual can have a better quality of life. With supportive care, the individual can continue to seek curative treatment options. So you can continue to see all of your doctors, continue to go to the clinical trial, you can continue to seek other second opinions, third opinions, and still receive supportive care at home. But in the contrary, with hospice, we have a highly skilled care that focuses on the mind, body, and quality of life. And in hospice care, curative treatment is no longer a goal, and instead the focus shifts to comfort care, keeping the person at home and having a dignified death. Myth number 2, palliative supportive care is the same as primary care. Even though palliative care can help at home, it kind of helps bridge the gap. So between primary care visits and just really keeping the patient at home, so if there is a patient that needs something in the home, for instance, if an individual is experiencing issues with pain or is having new respiratory issues or even medication management, let's say you went to a specialist and the medication is making you sick, because sometimes medications give you side effects. Our nurse practitioners can see the individual at home and minimize the need for a hospitalization. So there are sometimes some patients that have these side effects and then they end up hospitalized and they end up in the hospital for a week or so because of mismanaged of medication, or maybe not understanding how the medication is supposed to be taken. So our nurse practitioner visits at home can minimize hospitalization visits. Also, palliative care at home can involve nurse practitioners, doctors, nurses, social workers, and chaplains to support with physical, social, spiritual, and emotional needs. So palliative care is not just a nurse practitioner, but also other professionals that can help with other areas. Supportive care and older adults. How can we help our older adults stay in the home, age in place, age in motion? Because we know that a lot of older adults are still independent. They still want to go to the supermarket. They still want to do things on their own. Well, with supportive care, we are focused on reducing the symptoms, so pain and the stress of just dealing with the chronic or terminal illness. So if you are diagnosed with early stage of dementia and you're still kind of able to do things on your own, we can focus on managing those symptoms, managing on the pain, managing on the stress of dealing with it, explaining the disease. And then also the goal is to improve the quality of life and longevity of the person. It can be done in tandem with curative treatment, so you can continue to take your medications that you're taking and still receive this care. It is also covered by insurance. So it's like seeing a specialist. So it's a specialized care. It's comfort care at home, and it is just like seeing a specialist. It is covered by your insurance. And then we also work with the individual's healthcare team to ensure coordination of care, medications, and education regarding the individual's course of the illness. Supportive care is also provided as needed. So usually every 4 weeks or every 6 weeks, depending on what the needs are. Of course, if you're having any distresses or any issues at home, you can call your nurse practitioner and she can come out to see you again. We also discuss the goals of care and end of life decisions. So for example, if you are a newly diagnosed dementia patient, but this is now, in the later stages, we should probably start talking about end of life decisions such as financial planning, POA paperwork. Do you want to be resuscitated if God forbid you were to stop breathing at home? So all of these things are discussed with your nurse practitioner or a social worker. Myth number 3, hospice means I'm dying soon. Not necessarily. Hospice care is available for anyone who has been given a life expectancy of 6 months or less. But we do currently have a patient actually that has been on hospice for over 2 years. Because we are getting referrals earlier, we are seeing more people stay on hospice longer. And you're probably thinking, well, how does that happen? Well, we do something which is called a recertification. So the first time we recertify is at 90 days of admission, and then after that it's every 60 days. So every 60 days, a doctor is going to certify that the patient still has hospice eligibility, but you're still alive. So Medicare can understand that this patient is still in service. And we have to kind of prove as to why you're still in service. So basically just proving to Medicare or any other insurance why you still need that care at home. So hospice care, they can provide a comprehensive symptom management and provide support to the patient and family and caregiver. Sometimes the family members, they can hire someone, they can seek someone like Interim Health to come and help. And so we work together with them. Hospice care focuses on physical, emotional, and spiritual needs of the person. For instance, psychosocial concerns, resources, questions regarding what to expect at the end of life. So with hospice, we're not there all the time. We have a nurse that comes out once a week. And so that's why it's very important to have other resources like Interim Health come and help us with the other 6 days of the week in which the patient needs help. Hospice can be done anywhere where the patient lives. For example, at home. Most of our patients are at home. Some of them are in assisted livings, nursing homes, group homes. It just really depends where the patient is. Hospice can also provide respite care. So for example, if the patient is on hospice and the caregiver feels burnt out or they have an emergency, you can request respite care with either your nurse or your social worker, and we will find a place nearby or use one of our inpatient centers to provide that respite care. It's up to 5 days where we will be providing that care 24/7 so that you can have a breather, so you can have a moment to yourself. Inpatient centers are available for patients who have unmanageable symptoms and that qualify for that. So you have to meet a criteria. You have to be unstable at home. So for example, for any patient that has acute pain and you are now requiring IV medications, or you have a respiratory distress and 15 liters of oxygen is just not doing the trick, you may need the inpatient center to get you stabilized, and then we'll bring you back home once you are stable. Myth number 4, hospice makes the person die faster. We've heard this so many times in the community, and it's not true. Hospice care professionals, they can explain end-of-life decisions, all while keeping the quality of life in mind. And the goal is to provide a dignified death. Like I stated earlier, we have a patient that has been on service for 2+ years. We have had other successes as well. Patients actually can graduate out of hospice, and they can be transitioned to our continuum of care, which is palliative care. So, hospice goal is to support the individual, spend their time in a meaningful way and with dignity. We really want to make sure you're comfortable at home, you're not feeling any pain, and that you also understand what may or may not happen depending on your disease progress. our team of professionals, our nurses, social workers, the aides, and we also have a very great few volunteers that can help you with making new meaningful memories. For instance, legacy building, photographs, gardening, knitting. Just 2 weeks ago, I was able to see a patient at home that really wanted to go out to her garden. This is a younger female with, terminal diagnosis of cancer, and she just really wanted to go out to her garden. Well, the nurse made it happen. The nurse gave her enough medication to keep her comfortable, and the oxygen was by her side, and she was able to go to the garden and just feel the soil and plant her flowers. And a week later her flowers were blooming, and it just made her so happy to see that and to do that as well. And the counties that we service Anne Arundel, we service Prince George's, Charles, and Calvert County as well. The best thing about hospice is that we don't want to come in and just kind of take over the treatment or come and dictate, how you should continue your treatment at home. We really just want to work with your provider. We want to work with your team in the home. So if you have interim health in there, we want to work with them to make sure that you're okay, that you're comfortable. I think that's the main goal. But we also want to make sure that you're able to try to do the things that make you happy. We want to make sure that if you really want to go out to the market because you just really miss going out, that you have the wheelchair to do so, you have the oxygen to do so, you have pain medication to do so. We also want to make sure that if you need a hospital bed because you're no longer able to eat in the dining room table and you're eating in the bed, we want to make sure that it is a hospital bed that can, incline and you can sit up and eat. We want to make sure that you have all of the resources available. So that's why our social worker and our chaplain, they're very important because they play an intricate role in helping our families and our patients have all the support that they need. And then of course, when the patient is no longer with us and passes on, we also have bereavement services for the families that and caregivers that are left behind, right? Because we know that once the patient passes, another journey begins, which is the grieving journey. And a lot of times, with people that have chronic or terminal illnesses, it can be very hard to, if it's a long death, it's hard, and if it's a fast death, it's also hard. And so we help our families and patients, well, not our patients but our families, just really deal with the loss of a loved one. But that was all. Thank you so much. I am so grateful for the opportunity to share this with you. My information is on the screen. Please feel free to screenshot it, write it down. I am always willing to do informational visits in the home or informational phone calls just to kind of go over what it is more in detail.